Good morning everyone. Today I am going to talk about TMJ ankylosis. Now what is TMJ ankylosis? TMJ ankylosis is basically the adhesion of the components, anatomic components of the temporomandibular joint, that is the condyle and the glenoid fossa. It can result in reduced mouth opening. The patient is unable to open her mouth, his or her mouth, and it results in poor oral hygiene and also difficulty in protrusive and retrusive movements of the joint. Now it is classified based on the type of tissue causing ankylosis into fibrous ankylosis or bony ankylosis. Based on the etiology, it's classified as pseudo ankylosis and true ankylosis, and based on the site involved as unilateral and bilateral ankylosis, and based on the severity, partial or complete. This is the Shawnee's grading of ankylosis. He divided into 4 types: type 1, type 2, type 3 and type 4. This is type 1 ankylosis. Now radiologically if we see, then we will be able to see reduced joint space. There will be deformity of the condyle, or there can also be flattening of the condyle, and during the operation there will be lot of fibrous adhesions. This is type 1. Type 2, the periarticular area, only there will be bony fusion, not in the deeper areas of the ankylosis, only the periarticular areas will be involved. Then we come to type 3. Here there will be a bony fusion between the ramus of the mandible and the zygomatic arch. This is type 3 Shawnee's classification. And in type 4 there will be complete fusion of the bony ankylosis. Now taking into account heterotopic bone formation within the ankylotic mass, TMJ ankylosis was classified by Turlington and Durr as grade 0, grade 1, 2 and 3. Grade 0 is there is no bone islands visible. In grade 1 there are islands of bone visible within the soft tissues and around the joints. In grade 2 there is only periarticular bone formation, and in grade 3 there is very apparent bony ankylosis. Now grade 1, 2 and 3 are further classified as symptomatic and asymptomatic. What is symptomatic? Patient will either have pain, patient will have reduced mouth opening and problem in retrusive and protrusive movement of the jaws. Now we come to the etiology. The most common etiologic factors are trauma or local and systemic infections. Trauma can be either prenatal trauma, if the patient has undergone forceps delivery, that can be a cause. Then also trauma, the certain factors involved in the traumatic TMJ ankylosis are if the age is less than 10 years, and if there is injury to the disc, temporomandibular disc, or if there is prolonged immobilization after intracapsular fracture of the condyle. These are the 3 main factors responsible for traumatic TMJ ankylosis. The other factors are etiologic factors: myositis ossificans, osteochondroma, rheumatoid arthritis, ankylosing spondylitis, systemic lupus erythematosus, radiotherapy or surgical treatment of temporomandibular joint. One important thing is TMJ ankylosis is also associated with sometimes with the orthognathic surgery also. Now we come to the pathophysiology. What happens is there is intracapsular fracture of the temporomandibular joint. There are heavily osteogenic cells there. What happens is there is bleeding into the joint, hemarthrosis. Slowly the hemarthrosis gets organized, basically the clot gets organized into fibrous tissue, and then later bone formation takes place. The pathogenesis of ectopic bone formation is unknown. Basically the pluripotent mesenchymal cells, they differentiate into osteoblasts as well as chondroblasts in an unknown mechanism of stimulation, with the bone matrix as the most likely agent. So in unilateral ankylosis, what are the clinical features of unilateral ankylosis? In this patient we can see there is facial asymmetry. What happens is the right side is TMJ ankylosis, the left side is normal. Now the left side is continuously growing, so we will be able to appreciate the flattening of the left side, the normal side, and there is fullness or normal appearance of the affected size. It is just the clinical appearance is just the opposite of what is actually happening. There will be fullness on the affected side and flattening on the opposite side. Important thing is antigonial notch on the affected side. We can see it on the orthopantomogram. the antegonial notch. There will be class 2 malocclusion and very minimal or no condylar movements. And obviously there will be lot of caries because the patient is unable to open his mouth and maintain a good oral hygiene. This is a case of bilateral ankylosis. We can appreciate, this is known as a bird facies, whereas there is retrognathia, that is the lower portion of the mandible is not able to grow because both the joints are ankylosed. Typical bird face deformity with receding chin, the neck chin angle, this is the neck chin angle, is reduced or completely absent. There is class 2 malocclusion, the upper incisors will be protrusive and multiple carious teeth will be present, and also periodontal health is also very bad, and also there will be anterior open bite. Now the CT scan, before we used to have only OPGs, now CT scan facility is also there, so we can get to know the anatomic location of the ankylotic mass to the important anatomic structures like the internal carotid artery or the internal maxillary artery, which lies very close to the temporomandibular joint. Now there are various approaches to the temporomandibular joint. The few are the Blair's inverted hockey stick incision, Thoma's angulated incision, Dingman's incision, Popovich's incision, and also we use Alcaithan-Bramley's incision. Now what is Caban's protocol? Caban's protocol is first point. Early surgical management is very crucial for the treatment of TMJ ankylosis. There should be aggressive surgical excision of the ankylotic mass. Then after that we do ipsilateral coronoidectomy as well as temporalis myotomy. If after this procedure the interincisal mouth opening is less than 35 mm, then you go for contralateral coronoidectomy as well as temporalis myotomy. Then we go for lining with the temporalis muscle or fascia. Reconstruction of the ramus height with costochondral graft is done in children, and early postoperative mobilization should be there, it's a must. 50% of the work we will do and 50% of the work patient has to do for continuously 6 to 12 months, and patient has to come for regular follow-up. This is very important. And aesthetic orthognathic surgery is carried out after the growth is completed. Now how do you manage TMJ ankylosis? Basically there are three main steps: condylectomy, gap arthroplasty, interpositional arthroplasty. What is condylectomy? Basically condylectomy is just the removal of the superior head of the condyle. It is done for fibrous ankylosis cases. Therefore when the site of the fusion of the joint is mobile via condylectomy, then after arthroplasty, and alloplastic material can be used to maintain the joint space, satisfactory occlusion and joint movements. What is gap arthroplasty? Gap arthroplasty was first described by Abbe in 1880. In this procedure a block of bone is removed, either complete condyle or full thickness section of the bone, leaving a gap of 1 to 1.5 centimeter. That is known as gap arthroplasty. Complications are there. The internal carotid, the maxillary branch passes just medial to the condyle. So many times we experience a lot of which we can control by pressure or by with the gauze piece and waiting for some time. Usually it is controllable. Complications are common, and the operation may also involve ipsilateral or contralateral coronoidectomy to achieve satisfactory maximum interincisal mouth opening. Then we also do something known as interpositional arthroplasty. We place a material in between the condyle and the glenoid fossa to prevent re-ankylosis. Now there are various materials available. There can be autogenous, heterogeneous or alloplastic materials. Mainly we use in autogenous, we use the temporalis myofascial graft. We can use dermal fat graft taken from the abdomen. So there are various materials and they come along with various advantages and disadvantages. So we have to weigh the pros and cons and then use the suitable material. For children we use costochondral graft. From the 5th or the 6th rib we take the cartilage, because in few studies it has been shown that the condyle acts as a secondary growth center. So once ankylosis has taken place, so there is no growth of the mandible, so we replace it with the costochondral graft to stimulate the growth of the mandible. So this is done only for children, not adults. Re-ankylosis is of course a major concern, and therefore interpositioning of autograft is thought to deter this. Same procedure is followed, but the created gap interpositional material, as I have already told you. Using autogenous temporalis muscle as a myofascial flap is popular. Alloplastic interpositional grafts like silastic, proplast, Teflon, metallic fossa implants, acrylic marbles. However, they have met with more failure than success. One of the disadvantages of using metal is fossa is bone, and if we use metallic condyle, so if the patient has a trauma in the near future, it can directly go into the midbrain. So it is not very well used. Interpositional arthroplasty involves the creation of a gap, but in addition a barrier is inserted between the cut bony surface to minimize the risk of recurrence. Various autogenous materials I have already told you. Cartilaginous graft, we can use costochondral, metatarsal, sternoclavicular, auricular cartilage, temporal muscle as well as fascia, fascia lata or dermis. Heterogeneous grafts are chromatized submucosa of the pig bladder, lyophilized bovine cartilage, etc. Alloplastic materials are metallic, that is tantalum, 316 stainless steel, titanium, gold. Non-metallic are silastic, Teflon, acrylic, nylon. Temporalis fascia along with a varying thickness of temporalis muscle may be harvested, and an axial based flap on the middle and the deep temporal arteries are taken. The dependable blood supply, the proximity of the TMJ and the ability to alter the arc of rotation by basing the flap inferiorly or posteriorly makes this a versatile flap for lining the glenoid fossa. It is used as an interpositional material after release of the TMJ ankylosis. Basically, there are three goals of interpositioning. First is to replicate structural normal joint anatomy. Second is to provide functional articulation. Third is to establish an area where adaptive growth can occur. Costochondral graft, how it is harvested? We harvest it either 5th, 6th or 7th rib. Costochondral junction of the rib is chosen along with the some amount of the length of the rib, so that we can fix it with screws. The length of the total graft will depend on the height of the ramus to be restored. Minimum of 1.5 centimeter of costochondral junction should be included in the graft. The graft should be fixed on the lateral aspect of the ramus, this side, and fixed with a screw. A minimum gap of 0.5 to 1 centimeter should be kept between the graft and the glenoid fossa side, so that the free movement is possible without any friction. This is taken from the 5th or the 6th rib, and it is plated or fixed with the wires. What are the disadvantages? Increased operating time, additional surgical site, and then donor site morbidity, and also there is possibility of re-ankylosis, and also intraoperative complications can occur. Complications during TMJ ankylosis surgery, what can be the possible complications? During the anesthesia, as the patient cannot open the mouth, we have to do blind intubation, or we need fiber optic intubation. If fiber optic intubation is very difficult, then we have to go for tracheostomy also. During the surgery, there can be hemorrhage due to damage of any superficial temporal vessels, transverse facial artery or alveolar vessels, internal maxillary or pterygoid venous plexus can be there. Damage to external auditory matters because the cartilage lies very close, and damage to the zygomatic temporal branch of the facial nerve, damage to the glenoid fossa, damage to the auricular temporal nerve or the parotid which lies just inferior to it. Now, during the post-operative follow-up, there can be infection, there can be wound dehiscence, there can be open bite or recurrence if the patient fails to do the follow-up. Now, what do you do if there is recurrence of TMJ ankylosis? An inadequate gap created between the fragments can, that is, if it is less than 1 centimeter, it can lead to re-ankylosis. Missing on the medial condylar stump and leaving it behind. This is also one of the causes. Fracture of the costochondral graft can also lead to re-ankylosis. Loosening of the costochondral graft, if there is inadequate fixation, can also lead to re-ankylosis. Inadequate coverage of the glenoid fossa surface. Then inadequate postoperative physiotherapy, which is a very common cause of re-ankylosis. The patient loses to come for follow-up, and then slowly the mouth gets closed. Patient does not exercise. This is the main cause of re-ankylosis. Now we have to discuss about the technique of dissection.